Okay, this chapter is on blood vessels, and we'll also be talking about blood pressure control, which is very important to your studies and to the life of your patients. Okay, to start off with terminology, arteries take blood away from the heart. We think of arteries being oxygenated, but in pulmonary circulation, arteries are unoxygenated and veins are oxygenated. Same thing with the umbilical vessels. The umbilical artery has unoxygenated blood, and the umbilical vein brings oxygenated blood with food supplies and such back to the fetus from the mom. Veins take blood towards the heart, and capillaries are where the actual exchange with tissues takes place. This is a schematic drawing of the difference in arteries and veins. As you see, the artery is much thicker than the vein. The vein has these valves that prevent backflow. You have the elastic layers in the artery where you don't have elastic layers in the vein. And this is very disproportional because arteries and veins, major arteries and veins, are macroscopic, whereas your capillary beds are totally microscopic, just so you don't get that confused. Okay, now we call the wrappers around the vessels the tunics. Tunica intima is the endothelium. That's the inside lining of arteries, veins, capillaries. Tunica media is the muscle layer, and it also has sheets of elastin. Now, sympathetic motor fibers innervate these and cause a continuous vasoconstriction, giving them a sympathetic tone. When sympathetic tone is relaxed, then those vessels will dilate. Tunica externa is also called tunica adventitia. That's the outer layer. It's rich in collagen that protects and reinforces those vessels. Our elastic or conducting arteries, these are the big ones like the aorta and the branches off the aorta. Thick, lots of elastin, large lumen. They act as pressure reservoirs. They actually expand and recoil when blood is ejected from the heart. Arterioles are smaller arteries, and they get smaller and smaller until they finally lead into capillary beds, and they also control flow into the capillary beds using vasodilation and vasoconstriction. So for instance, if you're really cold, your body will divert flow away from your skin so you can conserve heat. Okay, capillaries are, they have the tunica intima, which is just one cell thick. And you have capillaries in all tissues except for cartilage, epithelial tissue, and the cornea and lens of the eye. These are for exchange of gases, nutrients, wastes, and hormones. This gives us somewhat of a schematic. The heart feeds into the arteries, and they get smaller and smaller and smaller until you have your little tiny arterioles, goes into capillaries, then feeds into small venules, which then collectively come together to make larger and larger veins until you finally get into your major big veins back to the heart. And we also have the lymphatic system here, and we'll talk about that more, but the lymphatics are there to pick up any type of fluids and debris that doesn't belong there, that escaped the cardiovascular system. Now, I'm going to mention again something we've talked about before, that at this capillary level, a lot of fluid is able to escape, and even at the early venule level, escape into tissues. I mean, it has to. You've got to let oxygen out, you've got to let nutrients out, pick up the trash that needs to be taken away. And so during that period of time, excess fluid can escape, and what pulls the fluid back into the circulation system is the osmotic pressure exerted by the blood, specifically plasma proteins. If plasma proteins are lacking, a good example is liver failure, then you will get edema because you don't pull the fluid back into the bloodstream. Okay, capillaries come in three types: continuous, fenestrated, and sinusoidal capillaries. Continuous, these are very abundant in skin and muscles. They're non-leaky, tight junctions. They do have a few cells that let fluids and small solutes go through. Now you have very good tight junctions that form the blood-brain barrier. And here we have a capillary that's continuous. It has pericytes, which are cells that go around the endothelium, and our endothelial cells, and has a basement membrane here. It's continuous, it's not going to leak stuff. Fenestrated, the word fenestrated means it has holes in it. Pores, fenestration, pores, and stuff can leak out of it because of these pores. So they're very permeable, and this is common in the small intestines, endocrine glands, and kidneys. For instance, you can't filter in the kidneys without having a porous membrane. Here are our little fenestrations. See, they're very small here. It's not showing on my marker. Fenestrations right here. Holes, holes. Okay. And sinusoidal, these have very large lumens, large fenestrations, and a lot of molecules, and even blood cells can pass back and forth between the blood and the surrounding tissues. Common in the liver, bone marrow, and spleen. Here we have our sinusoidal capillary. As you see, it's just got a lot of holes in it. It has big, large intercellular cleft, big holes right here, fenestrations. Okay, now, if the body needs to divert blood around a particular area, makes use of precapillary sphincters. Now, this is your capillary bed. The sphincters are wide open, and this entire area is in touch with the vascular system. Here, the blood is diverted by these sphincters here closing, and the blood just goes straight through here. It goes, it's a thoroughfare channel, and you get no, the sphincters are not allowing the blood to go out into the tissues, and it's open and closed according to the body needs. Now, after the capillaries, we have venules. Capillary beds unite, you get a venules. These are still porous fluids. White blood cells can get out easily. And in the early venules are just endothelium, pericytes, and then they get larger and larger. They start to have smooth muscle cells. Now veins, venules have come together and form your veins. These are much thinner than the artery, lower blood pressure than an artery, and they have a thin tunica media and thick externa, which has collagen and elastic fibers. And these are called capacitance vessels. 65% of the blood supply is on the venous side. Now, this is a photomicrograph of a little artery and a little vein. And as you see, this is round and thick, stayed up, and the vein is collapsed. That's just pretty typical. Okay, that's there. Okay, veins have specific adaptations that help return blood to the heart. It's pretty obvious how blood gets from the heart to the big toe. The heart pumps it, but you have to have several factors in line to allow it to return to the heart. First off, they have large diameter lumens, so you have resistance pressure. You also have valves, especially in the limbs. Now, this is a little diversion from the original context, but an anastomosis is an interconnection between blood vessels. It reminds me of Spaghetti Junction in Atlanta. Instead of just going straight through 75, there's all kinds of different ways you can go. And so you can get blood from one part of the body, can go many different directions. And common in joints, abdominal organs, and even in the brain. And we have shunts of capillaries are basically an arteriovenous anastomosis. Venous anastomoses are more common than our arterial anastomoses. Okay, another definition here, blood flow, and it's pretty obvious. It's the blood that's flowing, but you can define it as blood flowing through a vessel, through an organ, or through the entire circulatory system in a given period. Blood pressure is the force per unit area on the wall of the blood pressure, and we measure it in millimeters of mercury. And when we're talking about blood pressure, as a rule, we're talking about systemic arterial blood pressure. You could measure other blood pressures, venous blood pressure, or even the arterial blood pressure going to the lungs, but it would take specialized equipment. It's not what we're doing. We're measuring when we say taking your blood pressure. We're looking at systemic arterial blood pressure, and it is the pressure gradient that keeps blood moving throughout the system. Now, things oppose your blood pressure, resistance or peripheral resistance. It's your opposition to flow, and several things contribute to it. Viscosity, blood vessel length, and blood vessel diameter. Now, viscosity, how thick the blood is. If you have too many red blood cells, the blood is very thick and viscous. It's like trying to suck a Frosty through a straw instead of Coke. It's too thick. So that would cause resistance. The more vessels you have, the thicker it is. Length, and this is an unfortunate thing because fat, 1 pound of fat requires several extra miles of little microscopic vessels. It takes a lot of energy to push that much blood through those vessels. And so the heart has to work harder. The heavier you are, the more you have to work, your heart has to work. Now, resistance, the smaller the diameter of an arteriole, the more it resists, it provides resistance. You get changes in diameter due to sympathetic or parasympathetic stimulation. Fatty plaques, you fill them up with too much good food, barbecue, fried chicken, pork chops, lard biscuits, that kind of thing. That's all going to give you atherosclerosis and other things that change the diameter of blood vessels in a negative factor. Cigarettes, nicotine, vasoconstriction, and thus contributes to cardiovascular disease. Okay, blood flow is directly proportional to blood pressure, but inversely proportional to resistance. And resistance is easily changed by changing vessel diameter. When we look at blood pressure, we look at three things. The systolic pressure is the highest number, the pressure exerted during ventricular contraction. Diastolic pressure is the lowest level of arterial pressure. And if you can't remember which is which, remember when you die, your blood pressure goes way down. And then we have pulse pressure, which is the difference. You subtract systolic from diastolic, and that's useful for certain things. Okay, jumping around again, things that help venous return. First off, respiration. When you breathe in, you expand your chest. When you breathe forcefully out, squeeze your abdominal veins, and it's going to expand thoracic veins. And since you have a continuous, you have these valves continuously preventing backflow. This helps push the vessels forward. We do have some vasoconstriction of veins from sympathetic nervous system. This is a big thing. The muscular pump in your legs, arms, but especially in the extremities like the legs, contraction of skeletal muscles, keep blood flowing. See the little valve here? It's closed. It will only go one direction. So you continuously keep blood flowing. So your patients that sit too long will often have a lack of that venous flow and venous return. It can lead to swollen legs and even blood clots. Okay, to maintain blood pressure, we have to look at these factors: cardiac output, peripheral resistance, and blood volume. Now, blood pressure represents cardiac output and peripheral resistance, and cardiac output depends on blood volume. Changes in one of these variables are quickly compensated for change in the other. Now, how this happens, how we take care of controlling this, control mechanisms. First off, the nervous system. We have reflex arcs. A baroreceptor is a pressure receptor. Sends messages to vasomotor centers in the brain, medulla oblongata, and you have vasomotor fibers that respond, and they affect the vascular smooth muscle. So, vasoconstriction, just think about squeezing a balloon, causes increased blood pressure. Vasodilation decreases blood pressure. Increased blood volume increases blood pressure. Decreased blood volume decreases blood pressure. And the body uses all these to regulate blood pressure. It's just really two things: change in the dilation of the vessel, change in the volume of the blood. Okay. Vasomotor Center is a cluster of sympathetic neurons in the medulla oblongata, and they maintain a vasomotor tone. So we have a little constriction of arterioles. Now, that vasomotor tone, if it were to disappear due to anaphylactic shock, septic shock, then you lose that sympathetic tone, and the vessels just become very loose, and you have a tremendous drop in blood pressure. And that's why we give epinephrine for anaphylaxis. Okay, hormonal controls, the adrenal medullary hormones, norepinephrine and epinephrine, are going to cause two things: a generalized vasoconstriction and increased cardiac output. Angiotensin 2, and we'll go through how that happens here in a minute, causes vasoconstriction. Okay, this is a review from the chapter we had on the hormonal control of things, but the renin, if the kidney senses that the blood pressure is too low, it will release renin. Renin causes angiotensin 1, which is just in your bloodstream, to be converted into angiotensin 2 using angiotensin converting enzyme. Angiotensin does several things. It's a vasoconstrictor, so it directly constricts the vessels and causes the blood pressure to go up. It also causes aldosterone to be released. Aldosterone causes increased resorption of sodium and water, and therefore decreased urine formation. So you're increasing the fluid, and you have this vasoconstriction. It also stimulates the release of antidiuretic hormone. So you have a second reason why you don't urinate as much. Antidiuretic hormone, you don't diurese, so you can retain fluids. Okay, the adrenal medullary hormones, and we'll talk about epinephrine specifically, causes vasoconstriction. Now, alpha and beta blockers block the effect of epinephrine. Now, alpha receptors are very common in the actual vessels. So they, alpha receptors, I'm sorry. So an epinephrine receptor is in the vessels. So if you give an alpha blocker, epinephrine can't bind to those receptors, and you get vasodilation. Beta receptors are common in the heart itself. If you block those beta epinephrine receptors with a drug like Inderal, propranolol, then you block the effects of epinephrine. So the heart will beat more slowly and not as forcefully. Another hormone, atrial natriuretic peptide, is released by the atrium. Causes the kidneys to release more sodium and water. Therefore, you get a drop in blood pressure. Also causes vasodilation. So you have vasodilation and you pee more. And this is from the heart, atrial natriuretic peptide. Okay, going too fast. Let's see. Antidiuretic hormone is produced in the hypothalamus, stored in the neurohypophysis, also known as posterior pituitary. It conserves water. It also causes vasoconstriction. So antidiuretic hormone will increase the blood pressure. And I think we talked about in the hormonal chapter that drinking a large amount of alcohol will block the effects of antidiuretic hormone, and therefore you go pee more. Now, what you do need to be aware of is that drinking that alcohol has a short-term effect, but a long-term effect. It's actually damaging to your cardiovascular system and will cause high blood pressure. Angiotensin, we've already talked about this. Angiotensin 2 causes vasoconstriction, aldosterone release, retention of fluid. An ACE inhibitor, such as lisinopril, causes the conversion of angiotensin 1 to angiotensin 2 to not happen. One of the most popular drugs anywhere, not because it necessarily is a better drug, but because it costs $4 at Walmart drugs. Now, monitoring vital signs. You've got to do this on your patients every time you do it. You don't want to be that nurse that writes, resting comfortably, next hour, resting comfortably, next hour, resting comfortably, next hour, dead in the bed. That's not good for job security. Vital signs, pulse, blood pressure, respiratory rate, body temperature, and the pulse wave is caused by the expansion of arteries. Radial pulse is often used, but you can use many other things, and you should. Superficial temporal artery, facial artery, carotids, you don't want to over massage those, because if they do have plaque in them or clots in them and you massage them, you can release those and cause a stroke. You should check these dorsal venous posterior tibial arteries. You should check your feet. Make sure you got good circulation. Popliteal artery, here's your radial artery, brachial artery, and apparently that's better for small children. Now, the femoral artery, you can check in your patient. You got to tell them first. Now, I don't work with human patients. I think I've told you I'm afraid of primates, but I have checked the femoral artery on many patients. If it's a 1,200-pound stallion, you can still do it, but you got to ask nicely. And I know that your own patients are that way too. If someone comes up and grabs your femoral artery, you're probably going to kill them. Okay, the Sphygmomanometer. This is the old blood pressure machine, and the tube here was literally filled with mercury. And this, you can't really see it, but this marks the millimeters. It goes all the way up to 300. And the higher the pressure on this cuff, the higher the mercury goes up in the tube. So that's how we measure our blood pressure in millimeters of mercury. Not many people have little glass tubes of mercury running around anymore. Okay, and here we have the same thing I just said, but you attach the blood pressure cuff and increase it until you hear no more sounds in the brachial artery. And so basically the pressure in the cuff exceeds systolic pressure. Then you release the pressure until you don't hear any more sounds. And the first sound that starts indicates your systolic pressure here. That's the first sound. And that's because you have finally reached the pressure that is in the cuff that's equal to that in the artery because the blood's getting through. But it continues to cause turbulence. When the sound disappears, your diastolic pressure. And it should be, basically it says 110 to 140. That's not normal anymore. Now, it was 120 over 80. Now they want 110 over 70. The 140 over 90 recommendation caused people a lot of problems because they suffered with high blood pressure for years not being treated. Okay, variations in blood pressure, you're going to have changes over the day. In the morning, hormonal levels of such as especially cortisol are going to increase, and you're going to have should have your highest blood pressure first thing in the morning. Now, that's not always true because if you get stressed during the day, then the blood pressure will go up due to the stress. Other things that affect your blood pressure, age. The older you get, the harder it is to maintain good blood pressure. Sex, I don't know which sex. It used to be men had all the high blood pressure and all the heart attacks because apparently the women stayed home and cleaned house, watched soap operas, which would give me high blood pressure. And the men went and worked the high-stress jobs. Those days are over due to financial standards. Few people can live on one income. Now, weight. If you're overweight, it increases your blood pressure because of all those extra miles of arteries that are required to feed those blood pressure. Race, there apparently are some racial differences, but I suspect more of it's cultural difference. Like in some of the Asian countries, they don't eat some of the foods like we eat. They're more apt to eat something that's not fried in lard, which we know tastes much better. They don't cook their green beans with fat back. So it may be more of a cultural difference. Whereas in the South, we tend to eat food that's horrible for you and tastes so good. Whereas in the North, they don't even make sweet tea up there. I mean, how do you expect them to know how to cook? Anyway, mood, if you get really mad, blood pressure's going up. If you're chilled out, it's going down. Posture may vary, especially if you stand up suddenly, your blood pressure is going to drop. It may then adjust. If you're laying down, it could be higher, or when you lay down and relax, it may go down. Hypotension is low blood pressure when your systolic is below 100. Now, some people have a systolic pressure that's rather low, and they live a long time and have no problem. But extreme hypotension, if your patient has a 60 over 40 or a 50 over 30, you're getting into real danger zones because they do not get tissue perfusion, particularly to the brain and the kidneys. Orthostatic hypotension is when you get up too fast and get dizzy. Chronic hypotension, they always have low blood pressure. Maybe they have Addison's disease. With Addison's disease, they don't produce the right amount of aldosterone, or other corticosteroids, and they lose water and sodium. With poor nutrition, lack of plasma proteins, somebody who's not getting protein in their diet due to just not eating good proteins, or they have low protein because they're anorectic. Maybe they have parasites, disease, anything that causes plasma proteins to go down can cause low blood pressure. Hypothyroidism also causes hypotension, high blood pressure. Acute hypotension, that means they were fine a little while ago and now they got it bad. That's probably shock. Hypertension, high blood pressure. Now, this is wrong, and I should have changed this in the PowerPoint. This is the old data, 140/90. Realistically, the better rule of thumb is 110/70. If you can keep the blood pressure down to there, you have a much healthier individual. High blood pressure can be from, or hypertension, high blood pressure is the same thing. Fever, it's going to go up when you exert yourself. If you get upset, it's certainly going to go up. Certain medications cause increased blood pressure. So you need to, if you have a blood pressure problem, you need to read the labels on your drugs as well as tell your doctors. And this is a little off the subject, but don't take a medicine you haven't read the label on, all of it, preferably the prescribing information. You know, you can look it up. Okay, hypertension, prolonged hypertension is a major cause. Heart failure, vascular disease, renal failure, stroke, heart attack. Primary or essential hypertension, 90% of hypertension is from heredity. You chose the wrong parents. Diet, the food tastes good, the rule of thumb, spit it out. It's going to kill you if it tastes good. Obesity, just because of the miles of fat. Age, the older you get, the harder it is to control your blood pressure. Stress, if you live a stressful lifestyle, you're going to have hypertension. Diabetes mellitus can lead to hypertension. Smoking or any nicotine use, including vaping, can lead to hypertension because it's the nicotine that causes it, not the smoke. Nicotine causes vasoconstriction. Secondary hypertension could be due to kidney disease, arteriosclerosis, hyperthyroidism, Cushing's syndrome. Okay, blood flow through tissues are also tissue perfusion is essential for oxygen delivery, nutrient delivery, and removal of waste from tissues. Gas exchange in the lungs, absorption of nutrients in the digestive tract, urine flow, and you have to have exactly the right amount of tissue perfusion to get proper function. Vasoconstriction is due to sympathetic stimulation. Nitric oxide is a major vasodilator, and this we'll talk about in subsequent chapters, is basically what Viagra does is causes release of nitric oxide at the arterioles, but it does not work for generalized blood pressure very well. But where it does work, it works very well and was quite marketable. We'll discuss that more in a subsequent chapter. Okay, circulatory shock is any condition in which blood vessels are inadequately filled to meet body needs. The blood can't circulate and don't get enough, the needs aren't made and you can die. Hypovolemic blood loss or fluid loss. Okay, so bleeding, whether it's internal or an injury, vomiting, diarrhea, and presumably just severe dehydration from not drinking water and being out in the hot sun. That would be another cause of hypovolemic shock. The patient is dying because they can't circulate the fluid because they don't have any fluid to circulate. Vascular shock is from vasodilation and decreased peripheral resistance resulting from the vasodilation. Examples, anaphylactic shock, septic shock. Cardiogenic shock is when the heart just can't pump enough. The heart is gone. You've had heart attacks, it just can't sustain adequate circulation. Now, two circulatory pathways. Pulmonary circulation is the short loop that goes from the heart to lungs and back to the heart. Systemic goes all the way through the systemic body and back to the heart. Developmental aspects in the fetus. Several places we have shunt to prevent waste of energy in that fetus, basically. The lungs are not used in the baby. The only thing they need to do in the fetus is to grow lungs. They don't breathe. They're parasitizing off mom, which is what they're supposed to do. Foramen ovale and ductus arteriosus are two examples. Foramen ovale is the little hole in the atria. Ductus arteriosus is the bypass from the pulmonary trunk, the aorta. Ductus venosus is a bypass around the liver, and then the umbilical vein and arteries circulate blood to and from the placenta. Okay, this is a major diagram of the heart, of the heart and the arterial circulation. It's a little bit large a little small to see every little thing, but you can study it and look at it. But your heart's going down to your aorta, thoracic aorta, abdominal aorta, where it branches out to iliac arteries, also goes down the arms and up to the head. Few little things we'll show specifically. People ask me, what is the circle of Willis? We hear about that in class. This is a cerebral arterial circle. And kind of a nice thing about that is that if you were to get some sort of damage right there, the heart that should be fed by that piece of artery could be fed from over here. So you have a bypass around that piece of tissue. And you can study the rest of these. Few specific things I will mention here coming directly off the heart. The aorta has 3 branches before it starts heading down south into the thoracic and abdominal aorta. Okay, the first, and this is our right side of the body, because you remember we're looking at the patient, so turn your brain around and look at him the other way. First branch coming off is the brachiocephalic trunk, and it goes off in to the right subclavian and then the right carotid artery. Now, the next branch off is going to be your left carotid artery, and the next branch is going to be your left subclavian. Well, I missed right there. And it's asymmetrical. Few things here. We have left gastric artery, splenic artery. I'm trying to mark these and they're not marking. Gastric artery, splenic artery, going to our spleen, hepatic artery, and superior mesenteric artery right here. And I think that's about what I want to look at here. This is another angle. We looked at this in our dissection. Here's your abdominal aorta at the very bottom, and it branches here into your iliac arteries, common iliac arteries. This goes on down into the legs. Here you can see where the renal arteries branch off, the adrenal arteries branch off, and this is a phrenic artery going to the diaphragm. Now, let's see what we got next here. This is showing some of the superior mesenteric arteries, and I think that's all I really want to go through there, except you see your aorta going down here. Okay, and this is showing the iliac going down in here. Here's your femoral artery and these other branches. And these are this is the bottom of your foot, your plantar arch, dorsal pedis artery on the top, lateral plantar artery, median plantar artery, posterior tibial, fibular artery, anterior tibial, and popliteal. On our venous side, again, this is kind of small. It's hard to look at much. We'll look at some more details. But you can see, that the leg veins all feed into your iliacs, which come up into your vena cava. And then all this top part here feeds into the superior vena cava. At the upper part here of the body, we've got several things to look at. You again see a asymmetry in your jugulars, and you have the brachiocephalics and subclavians. You don't have a symmetry there. Some veins you may not have known about. This is the azygos. I think I'm drawing and I'm not. Okay, there. This is the azygos vein here. This is the hemiazygos vein. Those are under right here. These are underneath your vena cava. And then over here in your arm, and if you've ever tried to pull blood on anybody, you know that rules are made to be broken. These veins do not always appear where they're supposed to appear. But we have our, down here, we have our cephalic vein. We have our medial cubital vein here, basilic vein. Radial vein is going to be kind of small. And if you're trying to get a vein to stand, you just have to learn how to do it. Important here, we have our renal veins, we have our inferior vena cava, and our iliac veins here. This is showing mesenteric veins. You got your iliacs under here. Gastric veins. This is one that I actually did want to talk about a little bit. Okay, if you have thrombosis, a deep vein thrombosis, it might be sitting down here in your femoral vein, is big right here. If it is in that femoral vein, it's going to quite possibly break loose and go up here through the iliacs. And let's go on up here. It's through the iliacs. It comes on up through the inferior vena cava. And then here we have this picture, the inferior vena cava up into the heart. And I don't have a diagram of the heart, but it would go from the inferior vena cava into the right atrium through the tricuspid valve, the right ventricle, into the semilunar valve, and our pulmonic valve, and then that into the pulmonary trunk, which then bifurcates, goes two directions. And if it does, it can get stuck right there, and you die right there immediately, right then. So it's important to realize that if a person has a swelling in their leg, you always want to think about, if it's one leg, always think about a blood clot. You can have a blood clot down in here if the whole leg is swollen. If both legs are swollen, I would tend to think more of a cardiac failure, liver failure, something like that. If one leg is swollen, it's going to either be cardiac, if one leg is swollen, it's either going to be vascular, as in a deep vein thrombosis, or lymphatic, which we'll look at the lymphatic system very shortly. And this is just showing some of the lower leg veins. This, your great saphenous, if you get a peripheral blood vessel, a blood clot is probably going to feed into one of these little veins and get stuck in the turns. Even in the saphenous, it may not make that turn to go up into the iliac, and so you may be okay. Deep superficial clots are not a big deal. Deep vein thrombosis are life-threatening, and it's one of those die now things, so you don't want that to happen to your patient. And that's all on this. Thank you.